Audio Jungle. Audio Jungle. Audio Jungle. Audio Jungle. Audio Jungle. Audio Jungle.
Hello, everyone. Welcome back, I should say. Apologies for the little delay that we had. Sometimes, technical things can give you a hard time. So, hi, everyone, whoever is there. Thanks for your patience. Thanks for waiting. First of all, a happy World Radiology Day to all of you. And my best wishes to all the doctors who are taking IOPAs, who are in the field of radiology. May you rise higher and higher and higher. So I am Dr. Pallavi Mahajan, an endodontist, a writer, spoken word artist, and your host for the scientific sessions scheduled in DRDCA 2020. For those who are joining us for the first time, then DRDCA 2020 is a 1 month long virtual dental conference where we have a lot of activities planned. The conference started on 1st November, ends on 30th of November. The activities are you can take part in cultural competitions, you can attend scientific sessions. Details of everything is there on DRDCA FB page, as well as app, which I'm going to explain a little late after the session maybe. So, scientific sessions are scheduled for every Thursday, Saturday, and Sunday. Few sessions we have already done, many are left. Today we have four speakers with us, two in the morning session, two in the evening. The morning and the session today is little special because it's little out of the box thinking kind of sessions also and people also. There's a famous uh, quote by जावेद अख्तर साहब कि जहाँ जाते हैं सब जाना वहाँ अच्छा नहीं लगता, जहाँ जाते हैं सब जाना वहाँ अच्छा नहीं लगता, मुझे पामाल रस्तों का सफर अच्छा नहीं लगता, which means that I would rather take a road which is less traveled by, and rather than following, the all the people who are going in one direction. So those are the kind of speakers that we have with us today. The first speaker that we have is Dr. Gargi Roy Goswami, genetic dentist, founder Croynas, who's joining us from India. Dr. Goswami is an interdisciplinary oral healthcare professional, a geneticist and a general dentist by profession, an academician by passion, and a scientist by heart. And let me add, an entrepreneur. She has also been awarded the Dental Entrepreneur of the Year 2017 by FAMDent. She is the founder and director of IACDG, Indian Academy for Clinical and Dental Genetics. Dr. Goswami has this startup, Croynas, which is dedicated to her father, Dr. Kamlesh Roy Research and Diagnostics Private Limited. This is the first company in the country which caters to research services and training pertaining to dental genetics and saliva diagnostics. Other than this, she has recently initiated a platform which is named Cognos, Community for Engrossing and Novel Undergraduate Science, to encourage and uplift UG research in India, and it's purely a volunteer kind of work. To place a mark in the scientific community, Dr. Goswami pioneered to organize International Saliva Summit of India 2019 in Chennai and in Bangalore in January 2020. She has also established Genome Den, an online interdisciplinary e-magazine, also her YouTube channel, and free webinar series on saliva diagnostics and dental genetics. All these things, so much in the field of genetics, show that how passionate she is about genetics. Dr. Goswami is going to talk about why, and how of dental genetics, the various technologies and their applications in dentistry. It will also focus on the challenges associated and will provide insights towards a pathway to translate academic research into clinical applications. Now, I call upon Dr. Gargi Roy Goswami to enlighten us more about the topic and share her words of wisdom. Dr. Goswami, screen is yours.
Thank you. Thank you so much for this wonderful introduction. It's a privilege for me to speak in this versatile platform with so many eminent people inside your conference, and I think all of you are doing a fantastic job. So, okay, so with I think we got some technical issues, but I think we can. It's good to go. So let me just share my screen. Is it visible?
Yes, ma'am, you're good to go.
Okay. Good afternoon, good evening, and good morning, because I'm telling this as many of you might be watching from different parts of the world. So I welcome all of you today to this session where I will be taking you through a tour of dental genetics, a journey in words. So this is my platform of Indian Academy for Clinical and Dental Genetics, where I vision and my mission is to create, collaborate, and to contribute to science. With prayers to my dad, let me begin today's session. But before that, I must thank the entire team of DRDCA for giving me this opportunity, Dr. Raksan, Dr. Nupur, and each and every member who has been toiling hard to make this thing possible. It's a fantastic platform, and I think it's a very versatile platform where you are getting actually everything under one umbrella. All right, so I will make it very simple. As we all know that the human body is made up of billions and trillions of cells, right? And what do we have in cell? This is just cool biology. So in the cell we have nucleus, and in the nucleus we have what we really like to call as is DNA, the molecule of life. So can I put it in some other way? So just to put it that inside each cell we have a code of instructions for life, and that is nothing but DNA, or which is popularly the chemical name is deoxyribonucleic acid. All right. Now, as you know, that in our DNA, we have something called as genes. So what are these genes? These are basically some control switches, which switches on and switches off and keeps us how we are, how we look, how we eat, what we like, as well as whether we will be in our normal physiological health, or it's going to be anything bad happening, or we are getting diseased or acquiring in disease. So in our DNA, to make it in one straight line, I can say that we have both good genes or bad genes. So, and obviously, we all know when it comes to genetics or heredity or genes, definitely it's a very common thing that everybody know that genes pass on from the parents to the offspring, and these particular switches instructs the body how to function and grow. So, what are these good genes and bad genes? By the name, which is very obvious. So normal or good genes are those genes which let the body function very normally. And the abnormal or the bad genes are either a good gene becoming bad, which eventually it just disrupts the function of the normal gene, and this actually leads to many diseases. Like this actually makes the shift from normal to pathological. Okay, now I will tell you a very, very interesting fact. If you see that, in the entire world, we keep fighting for many things, for religion, for race, for color, and I know, what not. But if I tell that our when we talk in terms of DNA, and if I just analyze my DNA with yours or with anybody else's, our DNA is 99.9% similar to each other. Yes, it's not a story, it's a science. It's 99.9% similar to each other. So I think there is no reason to fight, and basically, we are all same when it comes to DNA. But what makes us different is just 0.1%. So the DNA between us differs just by 0.1%. And as you know, what DNA is made up of? DNA is made up of just four chemical alphabets. It's easier than an English language. In English, we have at least 26 alphabets and so confusing words, right? But in DNA, it's very straightforward. So what happens? The way these chemical letters are arranged in my DNA will not be same as it is in yours. So that therein the differences start. And this difference, though it is 0.1%, but it makes a huge difference because we can very well appreciate it. We don't have to compare ourselves with somebody else in other continent, but just see if we are just branches of our parents, but then we are so different from them also. So the combination of these four chemical letters, that is ATGC, adenine, guanine, thymine, cytosine, that's the interplay. The entire thing, entire human body, everything is running based on this permutation and combination and the difference between them. Okay, let since I am talking about little bit about genetics, then I must say the exact terminology. So this 0.1% difference we call in terms of genetics is genetic variation. So as you see in this picture, there's a plethora, I mean, many kinds of people together. So that is how we are. So due to this genetic variation, what happens is we are not identical. We are what we are. So how does this genetic variation happens? Very simple thing I will tell you. This genetic variation happens due to small, minute differences in the DNA. So what is that mechanism? There may be several factors, but mainly I will focus on something called as DNA mutations. So basically, there are several mechanisms when your and my DNA is becoming different by the process of mutation. So, for example, if I am having a DNA sequence which reads ATGC, a small change happens, and in you, the same portion of the DNA would read something else. It will not be ATGC, maybe it is ACGT. So, for that one small difference, you and I will be so very different in every aspect. So what happens is, due to genetic variation, we get different forms of the same gene, which in terms of genetics we called as alleles. So what do I mean by that? Um, like for example, let me just go back to this slide. So genetic variation results in different forms or alleles of genes. That means I will give you an example. For example, eye color. See, if you see eye color, if we can consider the eye color, somebody will have black, brown, then it can be bluish, it can be like cat's eye color. So how this is happening? So what I'm trying to say is that the variation, the characteristics or trait is eye color. But what are the variations? Those different brown, black, blue, whatever are the variations. So how is it forming? The main thing is same, but there may be small differences through genetic DNA mutations. That leads to the different forms of the same eye color. So that's genetic variation, I can tell you in a very simple way. But why should we understand this? It's a very, very robust information that with genetic variation we get. Obviously, we understand our DNA very well. What's going wrong, what's good, and what's not. So we understand that by understanding genetic variation. we can also understand about the susceptibility to a disease. So, what is susceptibility? It is something like my a tendency of getting a disease more, a tendency or a risk of developing a disease. You might apparently have nothing. Maybe something is there inside your family which is running in the genetics of the family. So that makes a particular person more prone to a particular disease. Here I will give you one small example. I think most of who will be viewing this session, we are all dentists. So basically, when we talk about oral cancer or any other disease, maybe not oral cancer, that's very complex. Let me just bring it down to, as a general dentist, I prefer to talk on dental caries. Have you ever observed in your clinical practice that if you follow a family, they will have a pattern of dental getting a dental caries, okay, in the tooth? Maybe the molars are more affected. Maybe they will definitely have a pattern if you have noticed. So what I mean to say is that if there is some kind of predisposition, we can understand it by understanding what exactly makes that person susceptible more, or makes he or her or him more risky to get that, or puts them at higher risk to get more dental caries compared to another person. Also, we can understand how a disease is progressing. So, through the information and understanding genetic variation well, we can understand how a disease, what is the rate of disease progression. We can also understand the drug therapy or whatever treatment responses that we are giving, what exactly is happening, how the person would be actually reacting to that. For example, here I will bring you another example. I think that's a very common one. Like, in many cases, what we see, or maybe the daily thing I will tell you that, like for example, certain drugs which some people are resistant to. Why is it so? So that why would be answered when we understand genetic variation, as well as when I'm giving some drugs or molecules or anything that I'm trying to trying to help that person or help the disease out, trying to make it normal. I can also understand what would be the risk of side effects. So just I will bring to your notice one thing. Whatever I told you here is something which I can understand even before a disease is happening. A risk of side effect, a risk of a tendency of a disease, a risk of getting a disease. So apparently it is not mandatory that the person will have any clinical symptoms or not. So that's the key to where the role of genetics, all these tools comes in. Okay, let me just move on and tell you. So, first thing first, why should we know about genetics in dentistry? That's the first question which is definitely running in your mind. I'm sure about it. So, let me just try to answer that. Well, first pointer is definitely to understand the normal physiology. I think this is a very common thing that you are seeing here, the tooth development process, which we have studied a lot. We have broken our head and to score good marks, but then do we really understand it well? There is so much intricate things that are happening and so wonderful. Have you ever imagined why our tooth anatomy is so different? Why we don't have incisors all in our mouth? Why we have a particular location for a tooth? Why molars doesn't pop up in the front? Have you ever thought? So think on all these things. So all the answers will come when you start understanding, when we correlate the genetics, molecular biology with dentistry. Second, my pointer is definitely if you see literature or if you see in your daily cases any dental disorder, whether it is a simple one like dental caries, whether complex one like malocclusion, or even dreadful diseases like oral cancer or any craniofacial deformities, everything has a genetic contribution. I mean, it has a genetics behind this because there is some problem going on there in the normal process. That's why we are getting these clinical symptoms. So if we understand the basis of the why of all these pathologies, we will have a better view, and definitely our way of thinking, seeing to the disease, the perspective, and tracking up the treatment protocol will also be changing for sure. Now, another thing is that number three is very important is to make appropriate referrals. Now, as you see, I have put a picture here, which is a condition called oligodentia. Well, you will tell me, okay, ma'am, we don't see oligodentia every time. It's kind of not very so common. But in some populations, it is very common. But why I'm giving you this example is that there is certain gene in studies. Researchers have found out that a particular gene mutation, which is responsible for oligodontia, is also responsible. The same gene is also responsible for causing colorectal cancer. Well, now you will be telling, okay, that means if I see a patient of oligodontia, that means I can conclude that he will have a colorectal cancer. No, absolutely not. But if you have this knowledge that yes, if I am seeing a case of oligodontia, and that means this person has this particular gene mutation, they might have it in them. So, is it not a good idea to refer this patient to a specialist who deals with, or a physician who deals with colorectal cancer? So, in this way, what you are doing, you are actually saving the life of the person, or maybe I will tell that you are actually improving, enhancing the quality of your life of your patient. I mean, he will be out of the blues. Why this dentist is talking to me to tell go to a colorectal cancer specialist? But then you are actually giving him the way to push that disease away. By any chance, if he has high risk, or maybe he has a tendency to get this colorectal cancer, it will be prevented even before the inception. So that's the robustness, and that's why you should understand dental genetics. And number four, now that I'm talking so much about gene mutations and all this stuff, so how, as a general dentist or a specialist dentist, how do I know about it? Let me tell you that research and science has advanced so much that now we know everything all about our genome. That has happened long back in 2013. We know everything. We know how many genes are there, what can be the disease causing genes, and that database is increasing day by day. And if you ask me that where can I find that, there are many biological databases which are available online and free of cost. You just have to go and, if you just want to understand one gene or maybe a particular disease, you just write it and you get the entire information about that gene or that disease or anything related to that particular pathology. So we need to learn these things, because the lack of genetics education is isolating dentistry from other healthcare disciplines. If you see medicine, reproductive biology, or many other fields, this has been very well adapted, and it is happening. And if you think that I'm talking something which is happening only in the first world countries, no, it is very much happening in India. Everything is available, only that we need to understand and connect the dots. Okay, so that was the four main pointers why we should understand dental genetics. Now I hope you will all agree with me that early diagnosis is the key, and pretty sure we always hear that prevention is better than cure. So if early diagnosis is the key, dental genetics is the power. So here comes my one branch one example formula, where I will tell you exactly, I'll give you one example for each branch of dentistry. There is too much to talk about, but we actually will not go into each one. I'm trying to give you an overview here. So, for example, if we take up oral medicine and radiology, so for proper diagnosis and referral, just now I gave you an example. So, I think the medicine specialist, oral medicine specialist, should look into in a more holistic, in a more broader way rather than a converging way. If we talk about oral and maxillofacial surgery, definitely the first thing that comes to our mind is craniofacial and developmental disorders. Orthodontics, you can actually predict by genetic studies. It has been already proven. And if you just go more inside and try to understand, we can predict a malocclusion pattern in a family. In periodontics, again, risk of getting caries or caries susceptibility. Periodontology is the most studied, is a branch where genetics, all these interdisciplinary studies are most done till date. So we can understand certain risk to aggressive periodontitis. This is just one example. There is so many, each branch we can talk days together. In prosthodontics, how if you can predict the bone loss pattern? So these are the things where we are trying to delve in, where literally we cannot see something with our eyes, but before that only we have the information. So that gives you, the dental genetics gives you that power. When it comes to endodontics, okay, now that you know that we know so many things about the oral microbiome and the microorganisms which are held responsible for dental caries or any other more infectious diseases. Now the hypothesis is changing because till date we were not aware that there are more and more microorganisms which we cannot cultivate in the normal microbial cultures. They are non-cultivable. So how did we came to know this? This is with the power of genomics, which is the tool that we use inside genetics. Okay, public health dentistry is a very, very important branch where you can actually do a whole lot of work, and you are the people who can bring up epidemiological population studies where you can segregate a population based on their risk. You can identify risk group, and you can actually define a treatment protocol, and not only treatment, maybe just with a lifestyle modification you can do much more good before, even before going into drugs or going into costly treatments. Okay, oral pathology, yes. So oral pathology, whenever we talk, it's some that comes the first time that comes to our mind is pre-malignant and malignant lesions, particularly if I talk about oral cancer, because I'm very fascinated about it. So we still are in a dilemma position, though oral pathologists are fantastic people and they actually go deep down into inside the cell in the whole of dentistry. If you see, they are inside the cell basically through the microscope. So the thing is that, but still we have dilemmas. We have places where we can't take this, we do not have a provision to make a decision that whether this lesion, which is apparently not looking so good, will it become malignant or not. Right now we just wait for the thing. We really don't implement those things where we can have a definitive diagnosis, or at least if not definitive, at least something which we can rely upon. Okay, and number 10, I have added it as a branch because I think now forensic odontology has come up like a new branch in dentistry, and many people, many science enthusiasts are into it. So in this again, the methods that we are taught, well, I will not speak here much about forensic odontology because I'm not a specialist in forensics, but as I know about forensic genetics, because like DNA fingerprinting, where you can actually pinpoint and identify criminals, you can do paternity tests by using DNA profiling. So all these, so I'm just showing in this one slide, I'm showing you the entire world which is there to explore. So please come inside and explore. So it's time that we should do this together. Okay, so okay, in this regard, I just wanted to mention that I do different online courses interdisciplinary. So I just started with oral cancer genetics, the November batch, and I think the July batch went very well. And it's a very versatile platform where professors, students, UG students, researchers from dentistry, biological sciences, it's an interdisciplinary platform. So you can just hop in my website www.genedent.com if you want to see the flavors and what people has to say about these courses. So let's move on. Now, this is a diagram which we study in our dental when we are a dental student, and we keep revisiting it. So this is what we are taught. This is the key factors that are responsible for dental caries. But let me just tell you how it changes when I bring in genetics. Yes. So when let me just go back again. So if I just focus on one thing, that is host and teeth. So what is there in host and teeth? What do we talk about at present? For example, if I put from a genetic perspective, I have so many things to understand in host and teeth. I have the tooth genes, I have taste genes, I have immunity, I have salivary, I have to understand the things that are happening with the surface dentition. There is so many things. Okay, I'll give you one example here. Like for example, amylogenin is a gene which is responsible for the formation of enamel crystals and their growth. So making it very simple, don't worry about seeing this complex what I've put. This is just that I'm trying to show that the amylogenin gene is present in human chromosome, X chromosome, and this is a location. So that is how we represent. Well, that's not of our interest at this point of time. So what I mean to say is that what can go wrong if this gene is getting any mutation. So if amylogenin gene gets any mutation, or if there is a change, let me just put it that way. So what can happen? Either the amylogenin production of the amylogenin protein would be abnormal. It might be excess or excess, or it can be something which is not amylogenin, or if there can be reduction in the amount of this particular protein, which will again, which is responsible for developing teeth. So what will happen? Consequently, there will be defective mineralization, and that if there is defective mineralization, it will definitely affect the bacterial adherence or resistance of enamel to the pH. What I mean to say, the ultimate result, what it will be, this person with a mutation in the or a change in the amylogenin gene will become more susceptible to get dental caries. So see, so this is kind of information which comes out, and this is kind of the information we should be aware of. Well, I am not telling that we in one night we have to all the dentists have to become geneticists and molecular biology. That is not possible. But can we not have a little more in-depth understanding and try to see where we can exactly connect so that we understand pathologies better, and once we understand pathologies better we treat them better? That is for sure. I mean, I can guarantee that. Okay, so I have just put up some potential areas of applications which you can think on. These are certain areas which much work is being happening, but you can think on delving in when it comes to your research projects or research proposal. Whether you are a general dentist, you are a faculty, you are a specialist, everybody can do. Everybody can do a small bit of clinical study or a scientific study based on their capacity, because for dental professionals the best thing is that sample is not a problem. Sample is not a problem at all. And I will tell you why is it so. So these are the areas that you see, which I already talked about, like oral microbiome, periodontal medicine, oral cancer, definitely, but early diagnosis. So there are so many applications. And if you see, I've put up a very fantastic quote here that potential means nothing if you don't do anything with it. So we have the potential, we just have to apply them. That's it. So where to start with? So obviously that question is there. Where should I start? Where to start with? Okay. So yes, to start with, you can think of body's mirror, or what we know popularly as saliva. So why saliva? Because saliva is a very versatile fluid, and there is so many things inside saliva, as we all know. And I think the composition, I don't have to tell you. There is proteins, there is ions, there is everything inside the saliva. So if I segregate them and tell them as biomarkers. So I get these tools of genome, that is when we deal with DNA, we have different types of RNAs, we have proteins, we have metabolic microbiomes, I mean the microbial world. So everything together, if I segregate and put, so these are the robust fields with which gives us the power when we combine them with the technology and these molecules of life, we get something called as salivomics. So these omics are the tools. So let me just tell you about that. So two most important tools that we can use are obviously a technology called as polymerase chain reaction. So where we can use this technology to identify many genetic polymorphisms or small differences that I was mentioning, that if there is a small difference between you and me or in the population how a disease is running, we can do this with this fantastic technology. Also a very advanced and robust technology where you can make decision making in cases where, like for example, I was telling that whether a pre-malignant lesion will have a malignant potential or not, you can use technologies like next generation sequencing. If you're interested, go back and just type in Google and you will see so much of information is there out about this. Now, for example, I will try to relate. If you see this particular first picture, it looks like malignant, but it is not so. When the biopsy and everything was done, it seems like looks very bad. Looks like it will become a cancer, but then it's not so. And in this case, there's a traumatic. It looks like a traumatic ulcer, but it has been seen that this turned out to be malignant. So at this point of time, as a clinician, when we see this, we don't have any choices to actually make decision or come up to a conclusion that whether this is malignant or whether this is not. So that's where I just gave you an example which I already spoke about. So in this kind of cases, we can use different types of technologies, like I already mentioned, molecular technologies, which will give you pinpointed answers, whether a lesion is going to be bad or not, whether it has a malignant potential or not. So that means even before the cancer is happening, you are able to do something because you have the information. Okay, so um, okay, so I think there will be a day where we can just spit in saliva and put it in a microfluidic chip and put it inside a machine, and that machine tells us, okay, these are the genes. So so these are the genes, and you can actually find out what's going wrong. So this is not a day which is to come. This has already happened. There are many devices which we can use. So maybe in India we have to work a little bit more. So how can we achieve these? We can achieve this by flow of innovation from academia to industry, and that is what I mean by bioentrepreneurship. Please think on this line, because as a dental student, as a dental graduate, or a dental professional, by virtue we have the element of entrepreneurship inside us. So I will give you a pathway from how you take your problem. We need to identify a problem in the society. We should have a vision to solve it, and then definitely we will have to see what would be that with my vision. If I'm trying to bring out a product, what should be the benefit to the society, and I will plan and make deadlines, and I will budget, and that will bring me to a place where I can try to be a entrepreneur or an entrepreneur and try to serve the society with my science and technology. So who can become a bio-entrepreneur? That's the question. Any science enthusiast can become a bio-entrepreneur. So what qualification you need? What you need? What are the key elements that you need? You need to be a graduate, science graduate preferably. You need to have a passion, and you should have a concept backed by robust science. Just these three things, and you are on. And there are so many things there. So we need money to do something. So there are several ways with which you can go for hunting money. The first one, there are many government grants and funds we can search for. There are many people where there are industry people who can collaborate with academics, and that is called as contract research organizations. They can help you. And third is definitely you can start somewhere with your own small savings, or you can just put one part of your income inside to build up a study, and with a mission that you bring up a device or a test that will really help, something, some chair side test, and with saliva life becomes very simple. So basically what I'm trying to say is that we are moving into an era where we are talking about personalized dentistry, and believe me, this is not new, this is happening for a long time. Just use these terminologies, and out of interest you can type in Google and you see what is happening out there. So here it's time that we stop a little bit, not stop, but I will tell that we refrain from these hit and trial things, and let us slowly move towards more focused type of treatment, where we it will be depending on the individual's unique genetic, genomic, clinical as well as environmental information. And how we can, if you have an idea, as I already told you, so there is a pathway to innovation. So that will take you to SALSI 2021. Please, it's a request, please attend this. This is a wonderful platform where all over the world people come, experts, scientists come, clinicians come to tell what they're doing with saliva. Saliva we can use it in dental, we can use it in mental, in neurology, in environment, everywhere we can use it. So I welcome all of you to the third International Saliva Summit of India, which we will be doing this time virtually, as you know, because of the pandemic situation. And the theme is Lab Bench to Chairside. It's happening from 29th of January to 31st of January. And we have many unique events, and where I will just highlight the main program highlights that we will be having. And I think it will be very, very versatile platform, because it's an interdisciplinary platform. Anybody from the healthcare as well as scientific industry, academics, students, study is welcome in this platform. So these are memories that we had when I could do the SALSI this in 2020 in IISC Bangalore, Indian Institute of Sciences, Bangalore. Okay, so let me just give you a little snapshot. So we have the global pioneers, we have national and international speakers. So we will have pre-conference sessions on chairside saliva diagnostic devices, where we will be giving demonstrations of these devices. Also some devices with which you can actually chairside device which are into development, with which we can identify COVID-19 as well. I have a special award dedicated only for undergraduate students, interns, and freshers less than 1 year, where you come, and if you have a good research idea, present it and take away cash prize. And that's Kriya, which is dedicated to my dad, Dr. Kamalesh Roy Research Idea Award for undergraduate students. We also have SALSI Influencers Award. SALSI, you can become a SALSI ambassador. And as usual, we have the poster paper presentations, and we have some unique programs where young people, young minds will show you how they will through a science drama, they will depict the theme of the conference from lab bench to chair side, as well as we have some interesting activities where you will also get a taste to feel about forensic genetics. Particularly, we will focus on DNA fingerprinting, and it's a really fun, I can assure you that. And we also have unique competitions where you can not only show, I mean, apart from the science, with science, you can show your talents. Like we have white poetry, where you have to make poetry with scientific words. We have edu reels, where you can take up anything from health and science, any topic, and make short videos. So all these things you will have. We also have rap genius. You can make, if you're good making at if you're good at making raps, then you can use medical words and make and a particular topic of your interest. And we also have panel discussions, particularly focusing on applications of saliva technologies into dental fraternity. And that's the hashtag you can follow everywhere in Twitter, Instagram, Facebook, and YouTube as well. So thank you so much. That was fantastic to talk here, and it was a privilege for me. And I would suggest to subscribe the channel, our brand channel, that is Learn Dental Genetics, where we keep putting small videos, less than 1 minute or less than 2 minutes, less than 1 minute, where we give you concepts about this fascinating field and how you can relate to them very easily. And also, I have another YouTube channel in my name, Dr. Gargi Roy, so you can subscribe. I do many madness, so you will keep watching many panel discussions happening. Some of the other event. Recently, we did something on how to, a mock research grant interview, when you really go and ask money, how exactly that happens. So all these things you can find, and many more we are trying to come up. And I have started an online e-magazine, as already our the host has mentioned about it. So Genomerin will come soon. And also I'm going to bring up a digital library, particularly focusing on saliva, which would be a free access to the entire studies, different from the different fields, as well as including dentistry, where you can just go in and search papers and read. And also you can contribute, and you will be showcased in our Genomedin as a top contributor if you're giving us good articles. So we are trying to build a database so that we get more and more enthusiasts. And just one thing, I will end it now here because we are running late. That, if okay, let me just stop sharing my screen and talk to you. So the thing is that if dentists start understanding the importance of saliva and genetics, nobody in the world can, actually compete. Nobody in the world, because we daily deal with saliva every day, in and out. We see a pathology right before, even from its inception, right from then the inception, then progress and everything. So I think you can just think on these lines, which I just tried to highlight. And I have a free Facebook group. Please join, where we keep giving information. I also have a page in Facebook. You can follow it. We give scientific information which you can very well relate, particularly focusing on dental genetics and saliva diagnostics. So I think with that, I will end, and thank you so much. So is there any questions that I can take up? Is there any questions that I can take up?
First question we have is how a very high risk of patient of dental caries respond to the genetic therapy? Like, have you experienced it? Have you seen it? Or what is your take on that?
Okay, that's a good question. But genetic therapy, when you tell, it becomes a very broad aspect to be explained. Particularly I will tell you very straight. This is a developing field. When we tell therapy, that means we are doing something with genetics, but still it is in the research level. Like definitely there are certain things where you can actually silence those genes, which makes the person to become more, makes the person at higher risk. Okay, but the thing is that we really don't have anything commercial right now. I mean, it's not like we have something that we can use in the clinic. That's what I'm telling, that these things we have to do. Yeah. Okay.
So, yes, ma'am. So, I think, ma'am, that was a wonderful session and very
Thank you.
informative because being in, being a practitioner, when we practice on patients, we actually don't realize that how genes play an important role. And this is something that we should go for. And as you said, sometimes we see a lesion also, we don't know what to do with it. Like, should we take a biopsy? What should we do? We just sit, we tell patient to wait and watch. And in the meantime, what happens is patient never comes back.
Correct.
Even if we have something like chair side mechanism, which you guys are doing beautifully, and I'm looking forward to even attend this conference of yours, the third International Saliva Summit of India, guys, January 29 to 31, 2021. And there's no reason not to attend it because everything is going to be virtual. So just like today, you can be at the comfort, you can be in the comfort of your place, take a blanket, cuddle up, and watch this session. Thank you so much, ma'am. It was an honor to have you here, and I'm
Thank you.
looking forward to meet you again. One
Sure.
more question has popped up: salivary IgA as a biomarker for COVID-19 pandemic.
Yeah, so yeah, now a lot of work happening in the salivary immunoglobulins. Yes, IgA, as not only IgA but IgA, IgM. There are panels, and people are coming up with more panels. But then here there are many things that we need to talk about, because when we tell about immunoglobulins, particularly salivary immunoglobulins, yes, you can tell it as a biomarker. But when you speak it as a biomarker, there are three things that you have to understand. You have to understand whether that biomarker gives you that facility of sensitivity, because here when we are trying to use a molecule as a biomarker, we have to see that whether it is available in the biofluid that we are choosing, whether it gives us a constant information. Because for example, why I told this, because for example, if I talk about salivary IgA, so salivary IgA is nothing but the secretory form of immunoglobulin
Right.
gene, which will be present inside the saliva. So if you're trying to do that, so some biomarkers with that, there will be diurnal patterns. I mean to say, salivary, maybe in the morning you have less, evening you have more. So you have to understand your biomarker very well. So only then a molecule, when you understand very well, we can actually tell this to be a biomarker, which we can use it for a kind of detection. So it is always better not to go for a single but a panel of biomarkers, whatever it is, whether it is immunoglobulins or any other thing that you can take up. Yeah.
Okay, ma'am. I hope the question is the doctor has got his question. Thank you so much. It was an honor to
Thank
have
you.
you here and talk about this field, especially. Very interesting topic, and I'm looking forward to see you again.
Sure.
Thank you so much, ma'am. Thank you so
Thank
much.
you.
Have a
Thank
nice
you.
day.
Same to you. Bye.
Yes, ma'am. Thank you. So that was Dr. Gargi Roy Goswami with us. Also, there's a link in the comments section where you can actually read her article, which gives an insight into the most interesting and unexplored aspect of dentistry, which is dental genetics. So just go through the comment section and get find that link. It is Dental Reach e-magazine November session, November edition. The article of Dr. Gagi Roy Goswami is there. So without wasting any more time, let me introduce to you the next speaker for the session. Uh, the next speaker is Dr. Sundar Jagdishan, joining us from New Zealand. He graduated from Chennai in 2002, holds a postgraduate certification in advanced oral implantology from Manipal University. He In 2017, in November of the same year, he did his New Zealand dental registration exam at School of Dentistry in Otago, and since then he is practicing in New Zealand. In November 2018, he graduated from the world-renowned Coase Center in Seattle, USA, to bring the latest and state-of-the-art dentistry to his valued patients. Dr. Jagdishan today is going to talk about comprehensive treatment planning, how and why to be health centered rather than process centered, how not to be a hitman but a healer, not to be a seller but to be a doctor. So let's learn how to be a doctor from Dr. Sundar Jagdishan. I welcome Dr. Sundar Jagdishan. Sir, the screen is yours. Hello,
Thank you,
sir.
Doctor.
A very, very good afternoon to you.
Thank you. Thank you, Dr. Pallavi. I'll just get this right. Thank you, Dr. Pallavi. Thank you to DRDCA for this opportunity and invitation. I take real pleasure to be with you guys today. I'm not an academic guy. I'm a clinician. I'm a general dentist from New Zealand. The presentation is all about we will be going only through clinical stuff, everyday activity based, what actually we do in the clinic. The whole presentation is based on my personal journey in the last 10 to 15 years of being a general dentist. Personally, a big thank you to Dr. Roxanne, Dr. Nupur, Dr. Manu, and the Dental Decoded Facebook page for the opportunity. And I wish DRDCA 2020 a grand success. This is my practice. I take pride in presenting a practice to my community, which is dedicated to your personal dental health. And I
Sir,
don't feel...
your share screen is not on, sir.
Sorry. Thank you. But can you see me now?
Yes, sir. The presentation is on. Yes, sir.
Thank you. Thank you, Dr. Pallavi. This is my practice in New Zealand, Napier. I take, as I said, I take much pride in presenting a practice which would cater to the health of a patient. And the philosophy of the practice is based on Dr. Coyce's principles in what I learned from him in Seattle, USA. The whole journey started 10 years ago, 10, 12 years ago, when I met Dr. Coyce first. For the first 8 to 10 years of my practice life, I had done dentistry, but I never understood why some of my dentistry failed and some of my dentistry worked. Even though we're doing the same procedure, same things again and again. But the fact is, some of our dentistry failed. Like, I'd never understood. I should take a leaf out of the previous speaker, Dr. Gargi Goswami. Genetics obviously plays a big role in everyday life, in a dental patient especially, but we fail to see that. And the same thing, we as dentists, as general dentists, because of our training, we go into a very process-centered approach to practicing dentistry. And that's exactly what I unlearned with Dr. John Coyce. And that's basically I feel I feel it with an evangelistic zeal that I should be sharing this with a lot of other dentists, so that as a group we could cater to our patients a bit more holistically and in a bit more health-centered way. So why do we need comprehensive dentistry? What is the need for? Why should we change tooth-based or a piecemeal dentistry? We'll take this example of this patient. A 50-year-old female new patient calls into the office with a toothache. The patient comes in and have a look at the situation. There is a PA being made, and the situation is a fracture of a tooth in quadrant 1, happened a week ago, and was slightly sore on the gum, not waking up at night. There's no spontaneous pain. And the patient had met another dentist before coming to me. This patient was given an answer by the previous dentist. This is basically what clinical notes from that dentist, which says he had done all the tests, everything seems okay. His option was to go for a crown lengthening procedure, do an elective endo, post-core crown discuss, but patient didn't want it. Patient doesn't want that option. One, for expensive cost reasons, but also patients not accepting a restorative option. That's basically what it is. So the dentist options at like The dentist is in quite a defensive mode at this stage, and he kind of steps back and says, we'll monitor the situation, we'll wait and watch. If there is a flare-up of pain, please come back and we'll take the tooth out or whatever it's like. But the dentist is not convinced that there is a room for an extraction option at all in this situation. But the patient wants an extraction only. Patient was unhappy with that decision from the dentist that the extraction wasn't done. So patient comes to me. What do I do differently? How can I make a sound, scientific-based clinical decision for this patient so that she will be happy, I am happy, but at the end of the day, we get a good clinical outcome for this patient and a long-term outcome, a health-centered outcome, which is what I'm trying to do. The answer to all these questions is comprehensive treatment planning. You got to take the patient in their context, in their life's context, in their financial context, in their health context, in their medical systemic health context, on their dental history, and also in their dental health context as well. And as famously said by Dr. L.D. Pankey, never has a tooth walked into my office seeking care. It's always a whole human being who's walking into your office. So what I would implore with every listener today is you start seeing the patient as a whole human being, not as a tooth. Don't be swayed by going into a treatment decision based on a single tooth's necessity. Do not give a treatment plan based on the needs of a single tooth. So what is comprehensive treatment planning? It is, in very, very simple terms, step back, taking time to think of and formulate treatment options for a patient after considering him or her as a whole person. Again, as I said, like it could be their financial background, social background, health background, and their mental history background. Always remember there's a mouth behind the tooth and a person behind the mouth. Why should we do this? Because if we go into a process-centered approach or a single tooth approach, by default, you become a process-centered, you're just zeroing in on one tooth. There's very poor occlusal management of any restorative strategy you're going to make, and which will result in an extremely poor restorative strategy. Very poor perio-restorative interface management. People, we always think as dentists, we kind of tunnel visioned into treating teeth and cavities, caries, and all those things. Yes, they are important, but you don't want to treat a tooth out of context. If you treat a tooth out of context, you will definitely encounter failure of your restorative work. Or as I underwent the first 8 to 10 years of my practicing life, I didn't know what was happening. I'm doing you could think about like you're doing bonding protocol. We spend such a lot of money learning bonding protocol. Bond, for example, is probably more expensive than gold itself. So if you think about all these things, practice profitability is extremely poor. And you kind of keep repeating work, you're kind of obliged to the patient, you're cutting a sorry face in front of the patient. And in summary, in conclusion, no one wins because of our piecemeal approach. I'm not taking a dig at dental education, but the blame has to start in our undergraduate education in effect, because we as dentists, when we are trained, my basic training was in India. The training was compartmentalized. In the final house residency, you're working in each department and your thinking is compartmentalized. You either look at a patient from a periodontal view or you look at a patient from an orthodontic view in a single tunnel vision kind of situation. That's exactly what I'm trying to break. And that's what I changed in my practice in the last 10 years. And I found that more satisfying and more comprehensive for the patient, and that's what I'm trying to do and teach and share the experience here. What are the advantages of comprehensive treatment planning in dentistry? First of all, we create patient-centered outcomes. Whatever the patient needs, you're looking at a patient and then you're deciding, okay, this is going to, I do a crown today. Can I, hand on heart, tell that this crown is going to last 10 years, 15 years? It's a patient-centered, long-term thinking is required by the dentist. As a dentist, we have to change our mindset towards treatment option. The other thing I just want to mention here is comprehensive treatment planning in dentistry is not rocket science. All you have to do is step back and think about each and every procedure you do for a patient should be a long-standing, long-term, predictable outcome. That's all you're trying to achieve for the patient. Be assured in yourself and your treatment planning process. Once you develop the system, the process in itself, which I'm going to just share in a moment, you will be able to deliver an outcome-based, a long-term outcome for the patient. You move from a survival mode in your private practice and to a success mode. Again, I'm not meaning a process-centered approach, but a person-centered approach. By default, you get a good occlusion management in the scheme of things. Patients ending up with efficient chewing, better aesthetic outcomes, and then all these things put together slowly puts your position in the patient's eyes as an oral physician, not as a mechanical dentist who is working on a tooth-based situation. Okay, how do I do it in this practice? The practice here we set up in 2018. This is my second practice in New Zealand, and we've set up, and this practice is entirely set up on Dr. Coyce's principles, which is the comprehensive planning at the bottom of the slide, the 5-point analysis. But before that, we want to take comprehensive care to a more person-centered approach, right? So my process starts at the pre-appointment staging situation itself. The process and the mindset has changed from the way I treat and train my front desk person. From the moment the phone call comes in, that's when the comprehensive treatment planning starts, or the treatment approach or the philosophy starts. And then it's the first interaction when the patient comes into your office, and then what kind of diagnostic records. I want to make a mention, the diagnostic records should never be expensive to the patient. They have to have an easy entry to access dental care. And then the dentist part, which comes into, is your comprehensive planning. The pre-appointment staging comes in like from the first phone call. The front desk person is trained in your philosophy. She understands your philosophy, and the approach is an extremely professional phone call interaction to start with. And I have a policy in this practice, and we try and fit a patient when they call us within the first 3 days maximum. Within 3 days, you got to see a new patient in your practice. And if we fail in that, we are failing in a person-centered approach. If it is an emergency patient with a toothache, we try to fit within 24 hours. And it's very simple. You can do it even if you have an extremely busy practice. You can do it by pre-blocking emergency times within your schedule. And as simple as that, we kind of schedule emergency blocks through different parts of the day, through the week. And depending on, say, for example, tomorrow, Monday, I have a block just after lunch, 2 o'clock to 3 o'clock is my pre-slotted emergency block. If there's any patients calling in with toothache tomorrow morning, my receptionist can put them in straight away. So the other thing also which happens in that pre-appointment staging is very clear instructions are given to the patient, which kind of sets up the patient's expectations about their first visit to come before they even come to us. And we follow online patient management software where the medical histories and the dental history questionnaires are sent to the patient on an email form prior to even they coming into the clinic for their appointment. And by this way, first thing in the morning, we go through I go through all the patients I'm going to see for the day. I'm ready for them from a medical point of view, from a dental point of view, dental history point of view, and also my staff are also ready for that. My dental assistant, she goes through the whole list and she's ready for the patient. Like we had a type 1 diabetic patient the other day who came in with a toothache, but we knew he was a type 1 diabetic, and because of the toothache, he hasn't had any food. This was like a 4 o'clock appointment, but he hasn't had any food all day, and he has had his insulin injections as per his schedule. The moment he comes in, we make an X-ray, boom, he's on the floor, he's flat. But because we knew his medical condition before, he even came into our practice, we were able to immediately cater to his needs, and we said, okay, he's hypoglycemic, we'll load him up with glucose, get the ambulance, put him on the schedule, and paramedics came and took him, and we took care of the situation. So the pre-appointment staging is extremely important from a medical stance, and also for you to cater to a person's needs to make that appointment as easy as you can and more effective and more productive for you as a business person as well. The first interaction, this is your second stage. The patient is in your office, they're coming in, and make sure we make this as a mission for our team, is to each and every new patient, each and every patient interaction has to be a remarkable experience. And we achieve this by a very professionally decorated practice. We take each and every step to make sure the place is tidy, modern, well presented, smells good. Dental offices smell very, that typical zinc oxygenol smell is something I used to hate it as a dental patient myself. And I never wanted that for my practice. And we have a receptionist who is welcoming the patient. Like it is as if I want to set up that reception in a way that as if you're walking into a 5-star hotel, and that's the ambience and that's the experience I want to give that patient. And because I care about them, they're not at the mercy of the dentist anymore or the learned doctor anymore. We need to present them with care, and also we take that responsibility even more to heart to give them an extremely happy, remarkable experience. We want to go above and beyond to make that patient comfortable. End of the day, in today's world, even with this platform, we're doing everything digitally. That human interaction is getting null and void in today's world. But there are certain industries, example dentistry, we can't work from home. We have to meet these people, meet our patients. Service-based industries, production and manufacturing industries, we still have to go to an office to work. And we want to make use of that human interaction, make the day better for each and every person who's walking into your office. This is a quote which has stuck in my mind for quite a long time. This is from Dr. Maya Angelou. I've learned that people will forget what you said. People will forget what you did for them. You could have done the best crown in the world for them, but people will never forget how you made them feel. If they went out happy, if they felt happy inside your office, they will come back to you. And this is how you express patient-centered practice, and you grow a dental practice as well. Then there's the clinical interaction, which comes into the play, which is, as a clinician, I'm more keen on this part. I've set the stage up, the patient's interactions come out really nicely, patient's happy, patient's relaxed before I'm seeing the patient. And then there are three parts to the clinical interaction. At this point, the dental receptionist, the front desk person, has handed over the patient to my dental assistant. So there's three parts to this clinical interaction piece, which is your dental assistant part, and then the dentist part, and then your hygienist part. Some practices, I agree, the dentist would do the hygiene part as well. Well, that's your call. But I feel hygienists are very, very, very unsung in our profession. We have to give them a far more credit than what they are being dealt with at the moment. They are the backbones of every dental practice. Every general dental practice should have a hygienist, in my opinion, and they should form the crux of your practice. They should be the linchpin in your practice. And we'll go through in detail with these three parts. And by the way, that's on that first picture on your top left side, that's my dental assistant and me working in on one of my patients. The second picture, and the third picture, that is my hygienist, Debbie. She's marvelous. She's such a wonderful practitioner, such a wonderful clinician. The most gentlest hygienist I've ever worked with. Okay, so this is my entry-level records. When a patient comes in, as I told you already, we allocate 30 minutes for this part of the clinical interaction. This is the dental assistant part. This is the dental assistant part. We allocate 30 minutes for this. A detailed medical and dental history is pre-done. Patients, we already have it on our system. It is very important because understanding the patient's current status is paramount if you're going to treat them comprehensively as a person. You need to understand their social and dietary patterns too. And my assistant gets my screening radiographs done, which could be either bilateral bite wings or you're doing an OPG. In my practice, it is an OPG, which is your entry-level record. And then my assistant also gets ready with 4 clinical photographs, which is your full face smile, a full smile close-up, repose close-up. Repose close-up is basically your rest position. For prosthodontals who are watching, they understand rest position. The rest position picture is easy to make. All you ask the patient to do is to say the word Emma and hold the pose. All you say is Emma and make that shot. All these can be done on a point and shoot camera. You don't need a DSLR. You could do it on your phone these days. There are flashlights which comes in with which can be attached to your smartphones. So 4 simple photographs, the dental assistant can do that. None of my clinical time is wasted here. An OPG is done. It's an extraoral radiograph, which is again, the dentist time is not wasted here. If you think about it, very simple records, entry-level records, and I go into the next stage, which is the dentist part. This is the crux of the whole presentation today, which is my 5-point dental exam. Firstly, I'm looking at the personal side. I'm also looking at the medical side, medical history of the patient, type 1 diabetes, cardiovascular issues. I'm looking at cancer patients, oncology issues, autoimmune diseases, smoking history, social history, drinking. In New Zealand here, we just came out of a referendum wanting to legalize cannabis. I voted no. I'm not a big fan of smoking and cannabis, but that's what's going to happen. We can't escape that. In America, there's quite a lot of people who states where cannabis is legalized. So smoking and habitual drug addiction, drug dependence is going to increase, street drug use. So you have a patient who is mixed up these days. Like today's 21st century patient is more open to drugs. There's more, it's extremely poor dietary practices. Due to that, there's extremely bad lifestyle choices. They are obese. There's not enough exercise. There's not enough health initiatives within their system, within their daily routines. Then you have your increased cardiovascular patients who come in. Allergies are getting more. Kids are being born now with nut allergy, peanut allergy, bees. There's awful lot of allergies out there. So you got to take, and I just want to make this note. There has been recorded deaths, people using chlorhexidine mouthwash. Who would think? Who would think people would be allergic to chlorhexidine? And I've had one recorded case I know of. A patient died due to an allergic reaction because of the preservative in then local anesthetic injection. So the allergic sequence is getting bad. So you got to be prepared as a clinician to see a patient before they even come in. The periodontal assessment, as I said, like before, as a dentist, we are always hell-bent on looking into tooth issues, decay, holes in the tooth, pain in the tooth, toothache, and that's what we are unfortunately wired up from a dental school. But you got to step back and take time to go through these 5-point dental exam. Periodontal assessment is paramount, and anything you do restoratively, if it is not done in the right periodontal context, it's a waste of time and money and effort. As I simply put to my patients when they question, no, I've come for a toothache, can you do me a filling? I said, like, you know what? I don't want to put your money into a dirty sink. I tell this to the patient. I might sound very rude to the patient, but they get that. You never wash dishes in a dirty sink, right? So this is a very simple example we tell the patients, and I use that exactly the way I told you now, and they get that. So as soon as that comes into play, they understand that this is the dentist who cares about me as a whole, and this is exactly where I tell you my hygienist role is extremely important in setting up a person-centered practice. Again, periodontal assessment is paramount because we now know that periodontal disease could not only be the result of diabetes, or it can also be a contributory factor. Again, genetic factors are important. You should know prior to the situation where you go into a restorative situation that the restorations are going to work, right? So you have to make sure that you're putting things in the right context. If genetically the patient is more predisposed to periodontal infections and constant periodontal therapy is needed, you got to step back and plan it better. And periodontal periodontal infection and the link to cardiovascular issues is just very well documented in the last 20-25 years. So I don't need to go through the details or convince you to understand the importance of periodontal assessments. Then we come into the tooth structure assessment. As dentists, I know every one of you are doing a fabulous job making the world a better place with restoring integrity. I'll leave it at that. And then, okay, I'll just add another point on tooth structure is we don't use camera or any caries risk assessment situation for further management of dental caries. So what I mean by that is a patient comes in, you find 3 cavities and you get 3 fillings done. And that's it. I stop there as a clinician, as a piecemeal dentist, I stop there. That's wrong. Patients trusting you with their care, right? So you have to give them a platform where they could have a situation where they will not have any more decay or not have any cavities in the future, or at least give them an environment, create an environment in their mouth so that you could avoid or minimize caries attack. By organizing fluoride, if your patient doesn't like fluoride, xylitol-based options are there. So whatever options based on camera, I would love to see camera become an everyday issue on your practice, everyday activity in your practice. Then we move into a detailed assessment of their temporomandibular joints. We normally don't do this exam in a general practice unless the patient comes in with specific TMD complaints. And that's wrong. To me, I should know whether I'm in a position by doing poor restorative choices. Have I created TMD? Hopefully not. So these are things which you should be assessing. And if there's occlusal disease, for example, there could be pathological occlusion, malocclusion causing restorative failure, tooth structure failure, attrition, abrasion, erosion, all these things. Environmental, is the chewing cycle being hampered, or the chewing cycle causing disease, or you're losing enamel or tooth structure issues. So all these things comes under the TMJ and occlusal assessment. And then we take the patient through an aesthetic assessment where we go through a full smile assessment. And all these things with my OPG and these 5 photographs, or the 4 photographs, we can do this. Probably, I give 30 minutes because I tend to kind of want to develop that relationship with my patient. So I spend probably 10-15 minutes speaking to them about what I have seen. But to the trained eye, once you have the habit of looking into these 4 photographs and your OPG and the first clinical look into the patient's mouth, boom, you could go get the whole thing done in 10 minutes. And then the next 15-20 minutes, you're explaining to the patient the need for comprehensive care, your philosophy, and the treatment plan you're going to present to the patient. Then my hygienist comes into the play. So the first 60 minutes the first 30 minutes is my dental assistant, then the second 30 minutes is me, and the last 60 minutes is my hygienist's time. So she goes in and does a entirely full thorough periodontal chatting, and then a full hygiene appointment as well, like an oral prophylaxis is done. Again, we want to insist on this to a patient who's coming new to your patient, because unless you tell them what they need dentally, there's no one else in this world who's going to tell them. And so you give the platform so that your hygienist can express her skills in a better way. And everything is based on getting a good outcome for your patient. Okay, remember this first slide we discussed, the patient who had this toothache? I'd like to go through an example of how I managed this case. So this patient was extremely unhappy with the previous dentist. She wanted an extraction. She decided that she needed an extraction, but the dentist said, no, I'm not going to do that because this is periodontally a very sound tooth. I'm not going to extract this tooth. I totally agree with the dentist. I don't have any qualms in that treatment option. But patient wants an extraction. She doesn't want to spend the money on a post and core crown lengthening. In New Zealand, it costs close to anything between $2,000 to $3,500, which is a lot of money for a person. Average pay, we are looking at $500 to $800 a week. So this is like a month's wages for a patient on one tooth. So before I give a treatment option to a patient, I want to make sure that I give them an option in their context. Yes, I agree that we are not giving any treatment plans prejudging the patient on a financial status, but whatever the patient wants, I'm here to deliver care for a patient, not for a tool. So this is exactly what we did for this patient. So we did an OPG, and as you can see this OPG, as soon as you see this OPG, there's a change in the treatment plan. Your thought process is changing clinically. My other thing is, like, I agree that the dentist has looked into the mouth in that previous appointment, but I don't think he looked into the mouth as a whole, but he looked into that one tooth, which was the offending tooth, which is tooth 1-4. The problem with this approach is, you look at this OPG, there's missing teeth all over the place. Patients used to dental extraction. Patients not keen on expensive restorative treatments. Patients coming in seeking an extraction. Patients' mindset is wrong. But in the context of the mouth, my suggestion, I agreed with the patient that I'm happy to extract that too. Patient's happy. But my point was, if I extract that too, what are we going to get in its place? Because I want harmony in the mouth. The bite has to be good. The occlusion has to be good. My restorative option or strategy should give them a good long-term predictable outcome, right? That's the whole goal of comprehensive dentistry. I'm not um, I'm not fussed about, I'm not obsessed about a single tooth anymore in my practice. I'm looking at the patient as a whole. How am I going to increase the odds of, or increase the chances of giving this patient a good chewing apparatus? That's my objective. If I could achieve that by spending $3,500 on that one tool, I would do that. I would present that, explain that to the patient. But in this situation, spending that extreme amount of money on that one tool is not going to benefit the patient. And this is exactly what I mean by comprehensive dentistry, is to the 21st century patient who is aware of what they need and what they want. So I go ahead and say, okay, I am happy to extract this tooth, but as a return, I want you to commit to getting a partial denture done for the upper and lower, so that we create some sort of balance or harmony in your occlusion. Patient saw that. Patient understood that. And immediately patient said, oh, yeah, you know what? No one else has asked me this. No one else, they didn't even tell me that I could do that. So this was a good outcome. End of the day, patient was happy. She got her extraction. I got my occlusal stability with an immediate acrylic partial denture on the top for the upper arch, and then tooth 1-4 was removed, and the final definitive prosthesis was an upper and lower metal partial denture. So patient has comprehensive care. I'll share this patient here because these are the photos you saw on earlier on my records session. So on this one, if you could see, again, patients are South African. They have quite a unique dietary style. There's something called a cured meat called biltong. It's a beef jerky kind of meat. Very high in vinegar, quite acidic food. This patient was very keen on his diet. He's not going to change his diet, but what that had done is that has caused quite a lot of erosion in his system, and so the whole treatment plan was based on how do we cater to this patient, or give that mouth a good environmental protection from that acid attack. So This patient we finished with some hybrid polymer restorations on his front teeth, and was a good outcome finally. And he had some caries issues, which we sorted out with these restorations. Periodontally, he was extremely sound, so going into restorative phase was easy. But how will I know my restoration is going to work here? Because I've done my 5-point exam where I know the patient's periodontally very sound. In fact, on the slide with my hygienist, this chart is this patient JB's chart. Actually, you could see there's a lot of greens there, a lot of stable perio there, except for the lower posteriors where there's kind of a moderate amount of disease, which we managed and which we educated him. He's back on a 6-monthly care with my hygienist now, and he's finally having a good outcome for his smile. There's no more sensitivity. That was his main concern he came to me with, because we've covered all that exposed dentine. Acid eroded dentine has been covered and restored. And we give the patient a good platform, occlusions managed, good erosion management, the choice of material which will survive in an acid environment better than straight Emax ceramics or any glass ceramics. So all these things starting to play into my treatment planning session, but the starting point is my comprehensive exam. We can only see a short distance ahead, but we can see plenty that needs to be done. I hope today I have given you a starting point, a trigger point for you to think comprehensively. Tomorrow morning, Monday morning, the first patient you see, I would love to hear from you that you guys are looking at the patient as a whole, look at their dental history, their medical history, look at them as a whole, their personal history, dietary habits, and then start to formulate your treatment plans from there. And I feel a bit cut short here, but there's a bit of time constraint with this system, with how we are working. I'm happy to do some question and answers. I have my email there, which I'm happy for any one of the viewers to come back to me with questions, how we do it, and the more brains we get into, more minds we get into these things, we will grow as a group. And thank you so much for the opportunity. And thank you, Dr. Robson. Over to you now.
Thank you so much, sir. And it's so true that we have to treat a patient as a clinician and not just a tooth. It's so important to focus on the patient as a whole and understand his needs, rather his or her needs, rather than just a tooth. Actually, I saw that case where you have showed the OPG, and I, being an endodontist, also would have tried to convince patient that I can save your tooth. Please go for root canal. Please go for
Yeah.
yes. That's what comprehensive planning means, right? We have to see the whole as not the whole patient we have to see and not just a tooth. So, there's one question, and it's from my side only.
Sure.
Sometimes it happens that even if we patient comes for pain in one tooth, and we know that we can do much better, but we don't we shy away from telling. We shy away from telling that to patient because we feel patient might think that we are just in the process of minting money or something like that.
Sure. Yeah.
So how to handle that situation when we know what is good for the patient, but the patient is not ready to understand?
Yes. So this is an extremely common situation we encounter in our practice as well.
Right.
So when a patient's coming in with a toothache, so we break this into two spots of action. The first thing is the actual phone call. The first phone call the patient calls us, we kind of pre-stage the front desk pre-stages the situation to the patient and explains to them or hints to them that my dentist is not going to see just the toothache. He will look at you as a whole person. He will look into the whole mouth. And we kind of prepare the patient's mindset at that phone call itself. And as soon as in that first interaction, when they step into the practice, we also kind of reinforce that whole fact to the patient. And then the first 30 minutes of time with my dental assistant, she also is speaking about comprehensive philosophy. So by the time I see the patient, my first agenda of creating a platform for the patient to understand the philosophy has happened. And then I come in, I go through the whole situation. Yes, if it is a toothache and the patient wants pain relief, you're obviously going to look into getting that tooth out of pain, like the patient out of pain. But you also start sowing the seeds into the patient for comprehensive philosophy. And I feel like if we could do that and make that patient understand that the whole point of you had a toothache now, I, as a clinician, want to make sure that you don't have this kind of toothache anymore in your life. And that's my starting point. That's how I tell the patient or get into their mindset and explain to them, you never want to repeat this. And then they suddenly open to discussing, okay, what do I do to not to get a toothache like this? And I kind of tell them, kind of play a joke, you know what? The next toothache, Murphy's Law says, will happen when you're in a holiday in Maldives or so we kind of make a joke out of it, but then they get the message. A
Right.
patient who's stung by toothache will never forget that toothache. I'm
Right.
not sure if you had a toothache yourself, but it can be
Fortunately, not
very
till now, but
irritating.
yes, I got one impacted tooth removed, and that was also a very not that good experience. So I don't prefer
True.
sitting on dental chair myself.
Yeah, we are probably the worst patients ourselves.
That's so true, sir. And so most of the clinicians, many of the clinicians, in fact, in India especially, I feel, they are new clinicians who have just opened up their clinics. They're just single doctor in their clinic. Maybe some don't have assistants also. So what will be your message for them? Like how to deal single-handedly with, and taking in consideration comprehensive treatment planning also.
My first thing is, as a general rule, I don't like solo practices anymore. I
Right.
used to be in a solo practice myself in a very extremely rural situation. I
Right.
was practicing in a town of 4,000 people. I was the only dentist in the
Okay.
town, and my nearest tertiary care was 150 kilometers away. So I've been in that situation. I don't enjoy that situation. It's not good for me, good for the patient as well. So group practices where we get at least 2 or 3 clinicians together is one, good for your practice, good for your patients, and good for your personal work-life balance as well. So as a young graduate, I understand, especially where we come from the Indian context, we have such a huge number of practitioners coming out of graduating every year, and everyone wants a piece of the market. My suggestion would be is to kind of collaborate with your classmates. Probably 2 or 3 can get together, start a practice, settle down with a philosophy. Each one will have their own interests, so you could start sharing procedures around yourself. But the crux or the basis of your practice should be your comprehensive philosophy. And once you grow that, and then you could start looking into different practices, and then always go as a minimum, either you get a hygienist with you or another practitioner with you, is my understanding after 18 years of being a dentist. This is what I would do if I had to do it again. Yeah,
Yes. And then sooner you start, better it is. Like you
I
learn.
would agree with that.
Yes.
Yeah,
Thank
yeah.
you so much, sir, for such an honest suggestion, honest opinion, and such words of wisdom, I must say, because being a clinician, also, we actually become process centered, like how a root canal was, whether it's fine. Even if patient says, ma'am, I have a little pain, we'll be like, it's okay, it'll get fine, don't worry about it. We have that
True,
tendency. So, yes, thank
true.
you so much for those kind words. And it was a very informative session. Thank you, sir. Thanks to be here and thanks on board. It was an honor to have.
Thank you so much.
Thank you, sir.
Thank
Thank
you.
you so much. Have a nice day, sir.
Thank you. You too. Bye bye.
Thank you, sir. Bye bye. So that was our morning session, and it was so nice to have, two different aspects that we hardly talk about. Uh, Dr. Gargi mentioned about dental genetics, the role of genetics when it comes to treatment planning, and how things can make a difference if we know it prior, if we know prior what are we treating. And Dr. Jagdishan, who talked about empathy, being empathy, that is such an important virtue as a human being also. And I think as a doctor, as a clinician, it is our duty to be, empathic towards patient, not just treat the tooth, but treat the patient, and not just in the process of saving one tooth, but save and guide the patient properly. No matter patient gets converted or not, your prime focus should be guiding the patient. On that note, we end this session, and I'm going to take your leave, but I'm going to come back again at 4 o'clock in the evening today, with two amazing speakers. We have Dr. Rishikesh joining us from India and Dr. Carolina from Uruguay. So go have your lunch. You have some time. Download the app if you have not done that. You have to download the Eventi app. Register yourself by making an account there. Then you visit DRDCA 2020 event, DRDCA 2020 international event, and you will be registered. That's it. What you get after that is around 40 CD points. In the end, like once the conference gets over on 30th November, 1 to 2 weeks post that, you will get an e-certificate on your name. So all those things will happen only if you register yourself. These videos are very much available on FB, DRDCA FB page, as well as YouTube. You can share the link with your friends. You can revisit them again, rebrush whatever you have learned, brushen it up, and all the things. But again, app will registering yourself will give you the certificate and 40 CD points. Also, there are some cultural events that are happening. If you are a passionate, if you are a dentist, along with that, you are a singer, a poet, a writer, a dancer, you can send your entries and you might be awarded. There are 3 days left for that. Also, there is one lucky draw competition, and one lucky person will get Novolace laser therapy machine. All you have to do is, again, download the app, take participate in the scientific sessions that are happening. Ask the questions, share the sessions, tag your friends. Also, you can take the screenshots while doing all these things and send it to us at drdca 2020 at the rate of gmail.com. I might have gone wrong with the email ID, so go check it out on DRDCA FB page. Every detail is there on the app, also Eventi app. You have to download DRDCA event. So that's it, guys. I will see you at 4 p.m. with two amazing speakers. Until then, have your lunch, go see a movie, chill, enjoy your Sunday, and come back at 4. Bye bye.